Hello friends, today we are going to discuss about something different about coronavirus. After 3 months of looking at the corona infection spread in India and whole world, my one question I asked to myself, do we really know a lot about corona and COVID? Based on that, I try to search the hidden aspect about this infection. So today I'm going to present this presentation or these facts in 4 parts. So I'll be posting on Facebook in 4 different parts, and I'll be discussing 4 different aspects of this virus. There's a lot of confusion which is happening. How this infection is spreading. WHO says that it doesn't spread by the air. There's no aerosolization. CDC says that doesn't spread by the touching people. But it is spreading. That is a fact. We thought of winters has gone, now it's a summertime. The infection won't survive, but it's surviving. Doesn't produce symptoms, but still spreading. So there are a lot of confusion I'm going to discuss in this presentation. So in present part, the first 30 minutes, I'm going to talk about infection transmission. This is very interesting part. And control measures which can help us, that is beyond PPE. So PPE will be a different presentation. So in the first part, in present one, I'm only going to talk about infection transmission. Friends, you, me, and whole public is worried. Why we are worried? Because our enemy is unknown, unseen, is invisible. Infection is spreading by the asymptomatic people who are just carrier with very high efficiency. So let's go through a fact. A person when get infection, like a exposed person, after 3 days it become contagion, means it become infectious. Okay, or you can say 2.3 days before the onset of symptoms, one human being become infectious. This infectiousness peaks 14 hours before the onset of symptom, and following that infectivity declined within next 7 days. Okay, if any human being who throughout become asymptomatic, who throughout is asymptomatic, it will present infectivity over only next 10 days. What is happening? One more fact I would like to bring in a notice. Asymptomatic and presymptomatic, there is a lot of confusion that I'm going to discuss, but regarding healthcare worker employees getting affected, you must have seen a lot of media reports that AIMS is, there are 400 employees plus are getting infected. There are, and many hospitals like Max, Gangaram, their people are getting infected, and you'll be surprised to know that those patients, those hospitals who are become now COVID hospitals, their people are quite safe. Their patients are quite safe. The visitors are quite safe as compared to non-COVID hospital. So over the time, non-COVID hospitals are become hub of contagion, not the COVID hospitals. Likely the precautions taken in the COVID hospital is pretty high. Most likely people working in like IT sectors, especially in the closed room setting without good ventilation, get infection, especially during mealtime when gear is down, when they are sharing their rooms like duty rooms. In the same home, if you're sharing the room and somebody is having infection, and during transportation, like in a bus or in a metro, people get infection. So we need to know how this infection is spreading and what extra we can do. Now, these are the facts which we know that even in ICMR, there are 33% more chances in healthcare worker is getting infection. This we all know. So this is an NHS study based on the app. It says that 11.6 times more chances that healthcare worker will get infected. But if he is not wearing proper PPE, then 26% chance is of getting infected. And even if you're wearing PPE adequately, because you work in that infected area, there are 5 times chances that you may get infection despite of wearing adequate PPE. And this was in the King's College London, this study was done. So these are the risks involved when you are working in a unit where COVID patients are there. Let's see what is the status of India. You may find Indian status is very different. You'll be surprised to see that even in our data, just 2% of the people got infection in COVID ward, and most of the people who got infection were not working in COVID ward. And now it's converted almost 80% to the COVID. So it's very safe for anybody, whether patient, whether doctor, whether visitor, or whether the people who are coming to OPD. Now, look at other institution data. The same thing is happening. 80 to 90% of the people working there are not acquiring infection from the hospitals. They're acquiring infection in the community. Because of community spread, the infection is much more in the people who are working there. Now, what I told you, that healthcare worker likely to get infection in through the community in a non-COVID area. So same study was done in Wuhan, and what they found that in frontline workers who are actually working in COVID ward, the incidence was just 0.5% as compared to 1.65% in the people who are working in non-front ward as a non-front barrier in a non-COVID ward. Now come to the second part. This is again very confusing. Asymptomatic, presymptomatic corona. What is this? Are they spreaders? Should we test them? Should we just leave them? They are just benign people. So let's try to define it. What is presymptomatic? Presymptomatic, as name suggests, a person who gets infection also symptoms as presymptomatic. So in a given human being, once it gets a contagion, 5 days is usual incubation period. Following that, they develop infection or symptoms, we can say. Now we come to the asymptomatic. Asymptomatic, after getting infection, if you get them tested by any means, by indication could be anything, but next 7 days, if they doesn't get infection or symptoms at all, this is pure asymptomatic. So 50 to 80% infection is being spread by these people. These are asymptomatic people. So that is a worrisome thing for everybody, especially for the healthcare workers. So as I told you, a pure asymptomatic patient, what are the chances that they transfer the infection? It is said to be 40 to 60%. I'm going to give you some examples of this pure asymptomatic patient transmitting infection. So probably it is not very clear about the recent ICMR study because it hasn't published it officially, but unofficially what we found that in community where there were red spots, or you can say there were contaminant area, they found that 15 to 30% of the community already got exposed to the virus. So my question is that if it is true, where these people got infection? This happened around 2 weeks back when almost 80% lockdown was there. So likely these people actually had asymptomatic infection. Following that, they found to have these antibodies which developed in them. And this was a study in the Italy also. So I'm going to present the asymptomatic part in form of super spreader. These are very interesting case reports. Some reports are with the CDC and some are otherwise on the net. Second, some studies, some beautiful epidemiological and microbiological investigations which are published in past 2-3 months. So I'm going to discuss with the evidence. Let's start with some super spreader. Look at this super spreader in the South Korea. This is a big building on the 11th floor. This is an area. You can see this one is an area. This is the typical area on the 11th floor. What happened here? An infected employee came, okay, on the 11th floor, and next 7 days, it was found that almost 43% of the people, those mentioned as a blue one, got infection out of 216. So 94 out of 216 got infection. What was different, on the other side of the floor, only 5 people got infection. Also, in the whole building, only 3 people got infection, though they were using the same lift. So probably CDC also said that likely it doesn't spread by the touch. So what we could gain from this study? Very likely it was droplet spread, because you can see lot of people getting infection on the same side. Fomites may not be very likely cause. Aerosol is again confusing. What is aerosol? These are small particles. Droplets are bigger particles. Aerosol are droplet nuclei which spread in the air, stay in the air for more time. So they can spread to the long distances. So there's a controversy whether this infection spreads through this aerosol or not. So, but likely that the people who got infection on the other side of the floor could be due to aerosol. Now, what we have understood till now, it spreads by touch. If you are in vicinity of any person who is infected within 1 to 2 meters, you get likely to get infection. But what we gained extra by this study, it is not the distance, but it is the time you spend in the vicinity that is also important. Now look at another study. This is a real story from Chicago. Name is imaginary. Day one, Bob, who is an asymptomatic guy, nobody knows whether he is having infection or not, shared a take-home meal, served the common serving dishes with 2 family members, and this dinner lasted for 3 hours. Now this Bob, after day one spending with the family, on day two, he attended a funeral, hugged a lot of family members. On day three, this Bob attended a family party with 9 other people and hugged, and again this party lasted for 3 hours. Look at what was the end result. End result was 2% from the family member, 1% from the funeral, and 7% from the day three, that is the party, got infected. So 7 plus 3 is a 10. But ordeal didn't finish here. Look at what happened. These 3 people out of this birthday party, next day they went to the church. Not next day, over next 3-5 days, they went to the church, they sang there, they danced there, and passed a teething dish. Okay, and the 6th member on the church also got infection from these 3 people. So ultimately, if you calculate 3 out of 16, though died, though 16 people got infection from this Bob, who was asymptomatic. Again, what we gained, it is not only the vicinity, the time spending there, and close proximity in a close space is very, very important. Now look at another example. This is a Singapore ICU, where a middle-aged man came with diabetes and hyperlipidemia as a history, presented as a community-acquired pneumonia who required intubation, that is tracheal intubation, with video laryngoscopy. After third day of, you can say, intubation, patient was extubated on NIV, non-invasive ventilation, we call it. Corona report came positive on day 4. This happened in 16th March. So that time there must be, gap between the sending the sampling and getting the report. Nowadays, these are not there. So what happened? 85% of the healthcare worker, means they were almost 42 care healthcare worker, and what we found that 85% of the healthcare worker was wearing surgical mask, and remaining were wearing N95 mask. So these 41 workers were placed under home isolation once the report was available, and to the surprise, none of the exposed healthcare worker actually developed symptoms, and though all the PCR reports were also negative. What we gained in this study, that this ICU was meant by negative pressure isolation. So adequate ventilation, especially negative pressure ventilation, helps in preventing this infection spread. And any mask, if you wear properly, can save the contagion to invade you. Now look at another study from China. This is very interesting, you can say, incidents where one man spread corona to 9 other people in a given bus. Okay, so same thing is applicable to the metro people. Let's try to see the sitting arrangement inside the bus. If you look at the sitting arrangement, this red one is a person who got infection. Okay, He was again asymptomatic human. And all these brown one, two, three, 4, 5, and 6, 7, and 8. Yeah, this one, blue one is 8. So these 8 people who were not wearing mask got infection. And once he left this bus, this another person from the pink came 30 minutes after this was the original person exited. And in conclusion, this infection spread 4.5 meters to the other traveler. It lingered in the air for the 30 minutes after original man got off the bus, and the person who came after 30 minutes, person who were wearing mask did not got infected, but all person who didn't wear mask got infected. So what we gained is very clear. Now look at the third one. This is a restaurant in Guangzhou. Guangzhou is the south of China. Okay, that time infection was not very much spread in the Guangzhou, but community spread has happened in the Wuhan. So the person, we call it A1. This is in the restaurant. Look at 6 meter. This is a 6 meter one. So this person came from Wuhan. We call it A1. This is A1. These are the various table A, B, C, E, D, F. Okay. So this person A1 came from the Wuhan. He was asymptomatic on January 24. Okay. And dined with the 9 friends over 1.5 hours. And what was the end result? 1, 2, 3, 4. 4%, almost say 50 people, 50% from table A, 75% from the table B, and 2 out of say around 8, say 20, 30%, 2 out of 7% in the table C got contagion, got infection. And what we could gain, that table E and F, there was none. Table D, there was none. And what they could draw is the flow of air. Flow of air was from the right to left. Look at the air condition. Look at the air condition and the vent. So this is your air condition and this is your vent. So flow was from air to air. So as FED didn't got affected, so there must be something related with the air conditioned flow. So they could see that probably the flow was from here to here. That's why people got infection from A to B. How the C got infection, likely it could be aerosol or it because of the turbulent flow. So likely that air conditioned with adequate flow, especially vent, should be adequately placed if we want to prevent the infection. Now let's go through epidemiological and microbiological investigations. There are only few standardized studies available which were done at the beginning of infection. Now it is not possible because of the community or local spread. Look at this is a study which was done, which was published in NEGM on 24th April, and in May 28th, it came in editorial. This was a pre-symptomatic SARS-CoV-2 infection and transmission in a skilled nursing home facility. It was a Snohomish County in the USA. So this was done in a very famous study as a Irons et al. And the main investigation team was comprises of the local team and CDC team. Okay, so start with the study. That first case on the March 3rd came to this county. Now, he was found out to be infected. Over next 14 days, they found that 48 out of 76 people got this contagion. So 64% of the people in the county got infection. 24%, 24 out of these people were pre-symptomatic. So 50% were pre-symptomatic. So they developed infection, they developed symptom later on. 7% or were totally asymptomatic throughout the study period. Okay, so let's see what were the conclusion. What they found that viral growth was present in 13 out of 20 people who got symptoms, 17 out of 24 who were pre-symptomatic, and 1 out of 3 who were asymptomatic. Look at, if we say symptoms start on the day 0, look at -1, -2, -3. This red one is a positive culture. This one is positive culture. I'm not talking about PCR because you may find that virus by the PCR. But these people actually had infection before they showed symptom. Okay, before actually fever, cough, and shortness of breath came. So these all were pre-symptomatic people. Now look at the cycle threshold. I'll be discussing cycle threshold in later slides. These are the cycle threshold which we get in quantitative PCR, and what it indicates the infectivity. Okay, what it was found that even in the asymptomatic person, the CT ratio, or you can say cycle threshold value, was quite okay for spreading the infection. This was around 20-25. As compared to presymptomatic were quite infective. This red one indicates quite infectivity, and lower the threshold, cycle threshold, lower the infectivity. So look at presymptomatic quite infected, atypical symptom patient having typical symptoms are quite infected. So if we talk about cycle threshold, whether it's a typical symptom, atypical symptom, presymptomatic, or asymptomatic, this was almost comparable. So what this study says, probably all the people, whether it's a typical symptom, atypical symptom, presymptomatic, or asymptomatic, all are infected. There is high potential they can give contagion to anybody, and this all is developing before they develop symptoms. Now, now come to a very interesting study which was done in Davao, Italy. And this we all know that this is a Venice and this is a Veneto where this study was done. Okay, this is read to be peer reviewed and still in medical archive. First death happened on the 21st February 2020 in that area. So lockdown happened there. During that lockdown of 15 days, the whole study was finished. Twice survey was done. First survey showed 2,812 patients. They did PCR of all these human beings. Lockdown was there, and the end of the lockdown, 2,343 people were surveyed. You can call it subjects. Okay. And what they found in the first survey, they found there were 73% people who were positive and 30 were asymptomatic, like 41% were asymptomatic. In second survey, they found 13 out of 29 were positive but asymptomatic. So total positivity rate was 29, means it was 29 out of 2000 plus population, but 44% were asymptomatic. Now, most interesting people were 8 out of all these. These were the new people, new patients who came from the first survey to second survey. So because of lockdown, actually they got infection from their nearby. So those nearby people were their relative, which were on the same floor. So extensive contact tracing was done. And what they found, out of 8 these new people who got infection, 4 acquired infection from asymptomatic carriers. Also, they found that viral load of asymptomatic carriers, that is based on the CT value, were almost similar, and there was significant viral transmissibility, you can say potential of these asymptomatic patients were there. So look at the positive one. This one is a patient number 2 who got infection from an asymptomatic without symptoms. This one is again who got infection from the asymptomatic. This one again from the asymptomatic. This one again from asymptomatic. So 30 to 40%, almost 40% of the people got infection from pure asymptomatic human beings who were residing in the same floor. Now, this is a beautiful study done which says that temporal dynamics in the viral sheddings. It's put in light on the temporal dynamics in the viral shedding and the transmissibility of the COVID-19. So what they made, an infectiousness profile was modeled there, and it was again done at a Guangzhou 8 People's Hospital. This is a Guangzhou, this is a Wuhan. So you can see the distance. This is a beautiful city of the China. So what they were able to conclude, they found that 44% chances that these secondary cases got infection from the index cases who were in pre-symptomatic stages. Okay, one more thing. Presently, our transmission is happening more than 30-40% in the pre-symptomatic or asymptomatic stage. So they also concluded that in any community, if your reproductive rate is 2.5, then contact tracing and isolation alone is less likely to be successful, especially because 30% of the transmission or more is happening before the symptom onset. So unless you do not contact and survey more than 90% of the contact, it's not possible to stop this infection. So that is very, very clear, unless we put up something new lockdown also. They also concluded, if you look at the primary case, this is a primary case. This one is a asymptomatic or pre-symptomatic stage. And this is a secondary case. You find that this is peaking, the infectivity of the primary case is actually peaking just before the symptom onset. So 2.5 days before the onset of symptom, infectivity starts. After incubation period, it is around third day. If I compare it with the seasonal influenza, look at the seasonal influenza. It's almost same, but peaking little bit later once patient develops symptom. But if you compare it with close brother, that is SARS, which spread in the 2003, the infectivity usually start after 1 day of the symptomatology. So in SARS-CoV-1 in 2003, it's easy to control because I know who is the enemy. If somebody is coughing, having cold, having body ache, I'll say, okay, he's infected. Keep himself away, keep him away, and isolate. But it's not possible in the present infection. Now, something about cycle threshold, CT, which I used. This is something new terminology for pediatrician, for doctor, for any human being. This is a value which usually we get in any report of quantitative PCR. This indicates an it indirectly represent the viral load detected by the quantitative PCR. So if you look at the various cycle, so around 25, around 30 plus indicates that less chances that virus will grow. So beyond 35 to 40, no live virus was found in any given human being. So this was a beautiful study which was published from the France. This was a game changer who changed the definition of discharge. Previously, I remember when the infection started, we used to keep patients for almost 14 days and we used to send two PCR reports before we send them home. But because of this study, because they correlated, what they found that though PCR were positive, but nothing was grown in the culture based on the CT ratio, CT threshold and the culture correlation. And look at this study, what they found that if CT is 13 to 17, 100% of the patient culture, or you can say specimen, grew cultures. The cultures were positive almost in 100%. But if CT is 33, only 12% grew culture. But if CT is 34 or beyond, there was zero culture. So they found that only after 7 days, the CT became significantly or high to be non-infectious, that is beyond 34. So beyond 34, your patient can be discharged. Though it cannot be extrapolated, this actual value, because many hospital centers are using different types of sample transportation, RNA extraction mechanism, and different type of PCR, different type of probe and primers. So the community says that try to have your CT ratio, your CT values for your given patient. And again, it is for the E genes. It cannot be extrapolated to ORF1 gene or N gene. So always remember this. So now try to look on the ratio or those CT values of your given patient. My question here is, I am asking the microbiology community, based on this was based we were discharging based on the CT value after 7-10 days. Suppose a patient comes to me on day 4, day 5, day 6 with positive report, but CT value is very high. That indicates the amount of infection is pretty low in this patient. So can we decide admission? Can we attribute the risk in this patient? Can we help in not isolating if CT is very high? Can we repeat the value and look at the CT value? Can we decide, okay, CT value is very high, we can take the patient to the theater? So these are the questions we need to ask from our research, which is being done by ICMR, and ICMR has made it compulsory for the people, for the everybody to give CT value also. Now I again ask myself why this virus is troublesome. Where is the problem? Why we are getting so many pre-symptomatic, asymptomatic? So what I found that SARS-CoV-2 actually replicate, the present one is replicating 2 to 3 times more than the SARS-CoV-1, that is the elder brother. So younger brother is quite smart. And there was a study which was published in 2009 by Vegra Breria, and they tried to explore the nasal cavity goblet cells. And they were able to see the goblet cells, nasal goblet cells, and also they found that now recently the SARS-CoV-2 actually get inhabited to the goblet cells. In these goblet cells, this infection become proliferative. So quickly it proliferates that it doesn't excite the immune system so that patient doesn't have symptoms. If doesn't have symptom, but it become very contagious over next 2-3 days. So that is the problem, that this infection, we call it SARS-CoV-2, gets into the goblet cells, and the entry, the receptors, like you can say a receptor which are required for this virus entry is very well present in the ciliated cells within the human, you can say airways, as well as in the nasal orbit, nasal mucosa. So what are these receptors? These are ACE2, we all know, but also TMPRSS2. These are the two receptors which are present there not only in the nose, but also they are present in the cornea of the eyes. They are present in the lining of the intestine. So this virus is still mysterious for human being. Now we come to the main part, the practical implication. That is why this infection is spreading. We all know that this infection can spread as a fomite. But what about droplet and aerosol? Every day we get new theory. WHO says that there is no airborne. CDC says that no fomite. What are these droplets? How this droplet behaves? We call it droplet biomechanics. This is very interesting to understand, and a lot of recent research has been done. So research started almost say 100 years back, 10 decades back, by Wells et al. If I can say, is a father of droplet biomechanics. What we already know, there is something like a bubble burst phenomenon that happened in the bronchi. This is a bronchus. And by this phenomenon, the layer over the bronchus breaks down. It becomes small burst, small, you can say, in form of small particles. And these particles get expelled through the airway, major airway. There are secretions in the pharynx that contributes to the large particles. And all these things get amplified by vocal cord movements and the cough reflex, and they get exited in form of droplets. What are these droplets? These are the small particles which are formed by mucosa, saliva, cells, and infectious agent if somebody is contagious. If it is small particle, less than 5 micron, in form of droplet nuclei or aerosol, it directly enter the lungs, type 2 pneumocytes, and directly get infected, creates infection. But if it is a bigger size, like 5 to 10 micron, bigger droplets, they either settle in form of fomites, another 1 to 2 meters, or directly enter the upper airway tract in a nasopharynx, tongue, and eyes. So what are the factors in this droplet which decides how long they are going to stay in the environment, how long they are going to travel? What are the droplet guiding factors? Let's see. The most important guiding factor is the weight and the size. Because we know that gravity is one thing which makes these droplets settle within 1 to 2 meters. The bigger the size particles settles very soon. Another very important fact is the speed of the expulsion. That the cough sneeze which creates lot of distance by the force, or it's a simple conversation of or expiration. Ambient temperature in the atmosphere, humidity is another factor, and another factor is very important, that is airflow. Airflow is another factor which we can work on. What we already know, look at this human being is coughing. The red and blue, green, there are three types of particles which are getting exited. Blue and green are macro particles. They will settle within a minute, within a meter from the human being. But look at the red one. They can spread longer, they can stay longer, and they can spread to every length. They may stay for 20 minutes. All studies were done in Japan. So based on this virus transmission, Dory Mellon studied which was published in NEGM. This was one of the earliest study which made everybody scared that the titer of viable virus was found in the atmosphere for more than 3 hours. Look at this one. This red one is R virus. And this was a Goldenberg drum which was studied how this virus actually spreads. Also, median estimate of survival was more than 1 hour. Now look at another theory which was published in JAMA and few other journals. There are two types of, you can say, droplet emission. One is we already know is an isolated droplet emission. Look at the video number A. When patient human being is coughing, these droplets are behaving like isolated droplets and will settle within a half a meter. But if particle size is small, as you can see in the B number, this can spread up to 1 to 2 meters. But what this study says, what this theory says, that this theory is known as turbulent gas cloud. And what it says that it doesn't spread as an isolated, but there's a cloud which is formed. And because of this cloud, the moisture is retained. Because the moisture is retained, because of that cloud, because of too many particles are surrounded with each other, you can say life of this each and every particle is 1,000 times longer than individual spread. So they have united. The virus has united with each other, but they have divided us and they are ruling us. Now look at the local airflows. Look at the local airflows, how this local airflow works. Imagine a closed door where there is very less airflow. Look at the aerosol after 20 minutes in the video number 1. This is persisting in the air. But look at the video number 2. 30 seconds after window is open, everything clears up. So if you open a door or put up exhaust, there will be early clearance. No question arises how this asymptomatic human being is spreading. There is no cough. How they can spread? They are just simply either sleeping or are with you, taking simple respiration. What has been studied by Seema Asadi from California, USA, by Chemical Engineering Department. This simple expiration also can lead to aerosolization, that is by fluid film burst mechanism. This got amplified by loud speech, and there is something known as speech superammeter. The superammeter speech, at times they produces 10 to 50 aerosol per second during conversation. And 10-minute conversation can yield a cloud of 6,000 aerosol. It has been said that simple speaking for 5 to 10 minutes may give you aerosol that is 2 to 10 times than the single cough. Now look at the left side human being, right side, who is speaking. This right one is generating lot of aerosol as compared to the person who is on the left side. So what it says that keep your voice low. Don't try to speak too much. Now we move out of the room. Look at what are the outdoor factors which leads to transmission of these droplets. How this droplet transmission get augmented by airflow. What it says that smaller droplet can move up to 11 meters if airflow is favorable, if flow is coming from the behind, as compared to bigger particle which can spread up to 5 meters. So 5 or 11 meters, so no area, no, you can say if somebody is not wearing mask, no distance looks very safe even in the outdoor. This was a beautiful study which was done in experimental model at 0 velocity of the air, at 4 kilometer per hour velocity and 15 kilometer. So what they found in the 0 velocity, droplet fell within 2 meter within 50 seconds. These were experimental studies not on the virus, but on the droplet transmission. Also, they found that if your speed of the air is low, like 4 kilometer per hour, the mass reduction doesn't happen. So this can spread not only to a distance of 6 meters, but the infection is more contagious. It's more infective. But if you find 15 kilometer per hour speed of wind is there, say from the left to right, chances that it will be less infectious as there's a mass reduction. So what they could able to conclude that 2 meter social distance may not be sufficient, though WHO to start with said 1 meter distance. This is another study which was published from the California, from the USA, and they studied the effect of weather condition on the propagation of respiratory droplets. So weather conditions are important, and what we knew from previous studies based on influenza transmission, on the hotter day, it doesn't spread that much as compared to the colder day. Let's go through the biomechanics of this droplet. This one human is A, which is spreading, the B, which can likely to get infection. Now, look at the A1. If it spreads the droplet, it should fall above the legs, okay? Then likely that B person can get lot of infection. Now, what are the various factors which affects the droplet? Look at this droplet, this green one, and this is the whole droplet. So evaporation, connective heat transport, air dragging, buoyancy, and gravity. These are the factors which affects the maximal spreading distance, which we call it Lmax in this study. So Lmax is a horizontal distance for all respiratory droplet. Droplet means bigger one, which get exited from the human A who is spreading. This will either become small droplet over say few meters by evaporation and become droplet nuclei, or will settle as per the gravity. And what we are going to find out, the Lmax, that is the maximum distance it can travel. So they simulated actual environment in a room. So what they found in room, the speed of air is 0.3 meter per second. Average temperature is 26 degree with humidity of 40 to 50. Average humidity they took at is 40 with air conditioned on. And what they found that droplet size of 74 micron can spread up to 2.5 meter before they become aerosolized. Also, they correlated with the temperature, and what also they found that this is the relative humidity. Look at the temperature, 40, 30, 0, 10. Lesser the temperature, more the distance this droplet spread. If temperature decreases, these droplets can spread up to 1.6 meter, up to 6 meter, not 1.6 meter. So they are expecting winters another 6 months. So they are worried that when winter will come, this will spread much more quickly and efficiently. Now look at, we were waiting for this hot and dry condition which we are passing through. Now, what will happen in the dry and hot condition, and what they found in the study, though the size of droplet, or you can say the infectivity and the distance traveled by droplet is going to decrease, but aerosolization will increase. Aerosolization means production of smaller particles, so which can spread beyond this Lmax. So what is happening in India because of hot temperature, the aerosolization is happening, and this aerosolization is going to is troubling everybody by more contagion. Also, they found that if the wind speed is favoring you, the infection can spread up to 23 meter by gentle, you can say velocity, gentle wind speed of 3 meter per second. So this virus is really, you can say, notorious, and it can not only spread, he knows that how to survive despite of adversities. So what we could conclude by this study, alone droplet protection, that is hand hygiene, is not going to be sufficient. Adequate air exchanges per hour is required, not only in ICUs but in wards also, in rooms also. Alone ventilation is not effective, and hot season is not going to finish this epidemic and what we are observing also. So it's not only having one vent and air conditioned, but it is the improper design of ventilation can lead to increase in contagion. So what we could conclude over past 30 minutes, it is not only the distance that matters, but is the time spent in the vicinity, because of aerosolization is important. Simple talk, quiet respiration is desirable, though it also spreads, but try to talk less. PPE is required to stop the small particles along with design changes. So we need to touch people less, keep quiet, keep distance, stay in the ventilated space, what we could acquire from the knowledge of the people who have done a lot of studies on based on the droplet transmission. Now let's see, these were all experimental models. Now let's see what are the evidences for aerosolization. What are the evidences? Suppose this is the room. If I collect the air, and in air, if I find the virus, I'll say aerosolization is actually happening. This was a study which was done in Nebraska. Another center, that was National Strategic Research Institution, they were involved in and mainly it happened in the United States. They tried to search for the evidence of airborne, and what they were able to find in an ICU, 63.2% of the air samples from the rooms of 11 patients, they got this infection. And some samples they found 6 feet away from the patient. And also they found that 66.7% of the 12 air samples which was collected from the hallways outside the patient room, they got infection. So definitely aerosolization is happening. Regarding surface fomites, they found that in the personal items like the exercise equipment, medical equipment, they were infective up to 76.5%. And though out of that, exercise equipment, medical equipment like spirometry, pulse oximetry, nasal cannula, personal computers, iPads, reading glasses were the most, you can say, fomites who got infected. Cellular phones, as usual, were got infected in 83% of the cellular phones, and the copies were significant. And remote control, which most of the people fight, and especially spouse and the husband and the wife, they fight for this remote control, and they found that 64.7% of the remote controls were actually infected. And regarding the toilets, one should not forget the toilets. They found 81% of the toilets were having contagion. This is another study which was done in the Wuhan, and they found in 35% of these areas they got this infection. That is, the aerosolization was happening despite of 16 air exchanges. And in general ward, in simple ward, where there were 12 air exchanges, 12.4%, 12.5% of the specimen they got from the air. Sorry. So based on these articles, this was a study which was done by, this is an article which was published in Environmental International and done by Lydia, and they pleaded to the international community that actually this virus is spreading by air, so please take it seriously. Again, by Chinese authorities, it's around a month back, they officially declared this coronavirus is likely to be airborne spread, and it is not by the just touch. But what WHO says is still there. They feel the study which was done, which showed that virus persisted in the air for more than 3 hours, that is a viable virus. They feel that this is totally experimental and doesn't match actual cough generation. And also studies which actually showed PCR positive in 60 to 70%. They thought that they may be dead virus. These were not actual live virus. So further studies are needed. So still WHO in the denial mode. Now question arises, why we want to classify? Because what happens if it is simple droplet, I need not to take care of the environment. So airborne spread infection, you can say control measures I need not to take. But if it is airborne, I need to take care of the air which is having this infection. Second question, how should I classify? Is it airborne or droplet? Let's see what are the different type of airborne transmission. We have forgotten a lot of things which we studied during our epidemiology classes in the third year. So I'll try to revise it. This is something known as obligate airborne. This indicates that the infection only spreads by the aerosol like tuberculosis. Second is preferential airborne like chickenpox or measles. They may initiate through multiple routes, but predominantly by aerosol. Another terminology is being used as the opportunistic. Under favorable condition like aerosol generating procedure, this can be artificial, this can be natural, like influenza and severe acute respiratory syndrome or SARS-CoV-2, which we are suffering from. They are classified as an opportunistic airborne infection, and our virus is getting lost of lot of opportunities. Now another question. Once we understood that, okay, aerosol is actually spreading, how much virus is present in the aerosol? And how much virus is required to be inhaled by any given human being to get infected? Very difficult to answer. So in this slide, not many things are very much evidence-based. They are based on the speculations, and except the first 3 lines. The single cough releases 3,000 droplets. This was all done by Well and lot of studies. Single sneezes can be up to 30,000. A single breath releases 50 to 5,000, and speaking is 5 times more. Okay. A cough can generate almost 20 crore of virus particles. Okay, an influenza patient can release 33 infectious viral particles per minute without cough. Okay, this is in a background done a few years back. So in this infection, it has been speculated that 1,000 virus particle is required to produce infection. So if we consider with every respiration, 20 minimum virus per minute is generated, okay, as compared to the influenza, not 33, but 20. So you require 50 minutes to spend in the vicinity, even if patient is not coughing. But if patient is coughing, you require just few minutes to have this infection. Though we talked about aerosol and the respiration, your toilet area is we feel is very clear, but it's not spared by this virus. It has been seen that it has been shown in the study that this has got orophycal transmission also. Many studies have shown that in stool it can last for 30 days. So it has been seen that if you're using toilet seat and flushing it and not closing the lid, if you don't close the lid, then too much aerosolization happen. You can see that too much blue one, too much aerosolization is happening, and it can spread, it can contaminate whole of your washroom. So if you are using toilet seat, definitely it should be closed before you flush, so that we can. Now, following that, once it has exited in the air, we know that droplets which are more than 5 or 10 microns settles within 2 meters or 3 meters. But what happened to less than 5 micron droplet? We call it droplet nuclei or small aerosol. So next part of the presentation, I am going to discuss that is based on, that will give us an idea how to control the environment. So see you friends for the next part of the presentation, and let's have good sleep. Good night.